A very good evening to everyone. It gives me an immense pleasure to welcome Dr. Srinivasan sir, our senior consultant endocrinologist in GKNM Hospital, who has an experience of more than 25 years. Yeah, we are honored to have you, sir, with us, who brings not only a deep knowledge but also a personal commitment to the health well-being. Please join me in warm welcoming Sir to speak on diabetes that affects millions around the world. Thank you, sir. Thank you for being with us in spite of your busy schedule. Without further ado, let's welcome Dr. Srinivasan, Senior Consultant Endocrinologist, GKNM Hospital, to deliver on diabetes. Understanding diabetes is essential. Stay informed. Please, sir.
Okay, thank you for your kind introduction and good evening, everyone. Thank you for inviting me to deliver this talk. As you said, diabetes is one of the important cause of morbidity and mortality in India now, and it is better for everyone to know about diabetes. Even if you are a health worker or not a healthcare worker, it doesn't matter. In the present situation, everyone should know about diabetes, and they have to be aware about how to deal with diabetes when one have diabetes in their home, or if they have diabetes, and how to manage the same. I want to share my slides to you. Could you let me in? Actually, I'm joined as a guest, so I couldn't share my slides.
Now?
Yeah, no, I'm able to. Can you see my slides?
Yes, sir.
Okay. Is it okay now?
Yes, sir.
Okay. So understanding diabetes is essential. So that is why in India, the Indian population has gone up to 146 crores now, 146.3 crores now. And the recent data shows that about 20 crores of people have diabetes in India. And, and there is another 20 million of people have pre-diabetes. So we need to see, most of you people will be engaged in managing diabetes as well, or dealing with patients with diabetes. So you need to be aware about what you're dealing with on the first hand. To begin with some history. So what is diabetes? This is a Greek word which means to stand apart, or siphon, which means that you pass a lot of urine as the day goes on. So passing a lot of urine is called diabetes. And the first recorded in English in 1425 as diabetes, but actually it is a Greek word. Then what they realized was both the Greek, Chinese, Egyptians, and Indians all realized that the urine passed by a person who has diabetes is sweet, and it is called mellitus. In 1675, that Thomas Willis had added mellitus to diabetes. So diabetes mellitus is passing a lot of sweet urine as an actual meaning. It was in 1776 that Matthew Dobson confirmed that sweet taste was because of an excess glucose in the urine, and the blood also has higher glucose values. So what is a diabetes mellitus? It's a chronic condition. So where there is impaired carbohydrate, fat, and protein metabolism caused by either lack of insulin secretion or decreased sensitivity of uh, tissues to insulin. As I've already pointed out, India has logged about 31 million new diabetes patients in 2019 to 2021, according to a study. And it is increasing in burden. And by 2045, the projectile, number of people with diabetes worldwide would be crossing about 60 to 80 crores. It might be even more than what they predict because of our lifestyle. We see most of the other endocrinologists or diabetologists would also agree that the number of patients with diabetes have gone up, number of new diagnoses has gone up, and the age of onset has come down. We are seeing more people with diabetes with less than 30 years of age. So it is surging in cases in India, and it's a global burden as well. So this is one of the important things which we should realize. The incident, the prevalence of diabetes in Tamil Nadu is about 8.3%. It is more than that. 8.3 would be less in my estimate. But if you take patients more than 45 years of age, there will be a more number of patients, where about 50% of patients have diabetes. So if you consider from 18, it will be like 12%. But if you consider patients who are above 50 years, it will be 50%. So this is mainly because of a problem with the hormone you will all be aware called insulin. Insulin is a hormone secreted by beta cells of pancreas. And this promotes a glucose transport into the cells and turns glucose into energy for the body to use. So this affects the carbohydrate metabolism, lipid metabolism, and protein metabolism. If there is deficiency, you can have problem with these metabolisms and mainly diabetes. So lack of insulin causes buildup of glucose in the blood, hyperglycemia, and in glucose, if it goes beyond a certain limit, they can have symptoms of diabetes. So what are the types of diabetes? Previously, they had a lot of types, but they have shrunken that into 4 main types. One is type 1, type 2. We will go through what is type 1, type 2, and gestational diabetes. Gestational diabetes is diabetes which occurs during pregnancy. I'm not going to touch much about gestational diabetes. And the others is due to endocrine causes or due to secondary causes like pancreatitis or damage to pancreas due to different other reasons. So coming to type 1 diabetes, there is a lack of insulin production by beta cells of the pancreas. So that is the main cause of type 1 diabetes. So injury to beta cells of pancreas or disease that impair the insulin production can lead to type 1 diabetes. What are the reasons that it could occur? It is because of, could be a viral infection, triggering the autoimmune disorder, or there is a hereditary tendency for beta cell degeneration. These all can lead to, type 1 diabetes. But type 1 diabetes mainly occurs due to autoimmune disorders triggered by other things like viral infection, which can trigger the autoimmune destruction of beta cells. What happened? Previously, before the previous century, that was 1800s or before, even before that, type 1 diabetes was considered as a death sentence to a patient. See, many younger people did not survive longer after the diagnosis of diabetes. They used to lose a lot of weight and they died because there was no remedy for type 1 diabetes. They were asked to starve or asked to take protein alone. But the game changed in 1921 when Banting and Best. Banting is one of the orthopedic surgeons and Best is his assistant. What they went up with a proposal to MacLeod, who was a physiologist in University of Toronto. And they together MacLeod was not, positive about the findings of Banting and Best, but he provided them with some dogs and also a room to work with. So this, they had a lot of dogs which were pancreatized. They removed the pancreas and
Okay.
obtained the extract from that, and they
Islam எதுவும்
injected the
அனுப்பலையா?
extract to the
ஆஹ்
patient.
பண்ணி நல்ல சும்மா தெரிஞ்சுக்கலாம்ல, சும்மா தானே இருக்கீங்க
I
ஒரு
think
நாள்
somebody, I think somebody is talking. Can they mute their mic? Can they?
Annapurni, Miss Annapurni Bhaskaran. Kindly mute yourself, ma, please.
யாரையும் மியூட் பண்ண சொல்றாங்க மகாலட்சுமி.
Annapurni Bhaskaran.
They had a lot of dogs and often obtained from dubious sources. So what they did is they removed the pancreas and took the extract out and injected to the same dog. And they saw whether the dog survived. So this was one of the famous pictures from Banting and Best. And this was the dog. They made the dog survive for about 10-15 days or a month by injecting the extract of pancreas after removing its pancreas. So this was the first dog. This was named as Marjorie. And this was a man who had the first injection of insulin. So regarded as the first person to ever receive insulin in the 11th of June 1922, aged about 14 years. He lived up to 13 years and before he died in a car accident. So what previously they had impure insulin. They have to give a large amount of insulin. But the other person who was called Colip was, immunologist. He purified the insulin and made it, more available to the patient. So here we have sophisticated insulin, which we will see in the next few slides. But previously, they have to give a large amount of volume of insulin, volume of medicine to give even 1 unit of insulin. So they received Nobel Prize. Banting and MacLeod received Nobel Prize for medicine in 1923. Banting gave his half to Best and MacLeod gave half to Colip. So coming to type 2 diabetes, which is, most common one, which affects most of the people in India, is, one of the common types. And it was previously called as NADDM. Now it is called as type 2 diabetes and accounts for about 90% of all cases of diabetes. See, type 1 diabetes is one which occurs without any reason. So you won't be able to really stop a person or prevent a person having type 1 diabetes. But type 2 diabetes is preventable. I always tell everyone, even my patients, attenders, to be aware and be healthy, because this is the one which is inflicted by the person to themselves. It is caused by obesity and the age. Previously, it was 45 years, more than 45 years. Now, even after 30 years, you need to be aware and be careful about your health. Otherwise, you can have diabetes, which is a mother of all the other problems, which we will see in the next few slides. So physically inactive, if a person is physically inactive, you will be sitting most of the time in a chair, which will not be ideal for your health. So you need to get up and, walk around or do some upper limb or lower limb exercises and sit down and do your duty after that. So positive family history, high cholesterol, high blood pressure, and if they have GDM in the past, that's an higher risk for developing diabetes at a later stage. So coming to the signs and symptoms for type 1 and type 2 as well, in men and women, they feel always hungry, always tired. They can have dizziness, frequent urination, that is polyuria, polydipsia, nocturia can also occur. They can have sexual problems, blurring of vision because of very high fluctuations in blood sugar, tingling in hands or feet. They might feel always thirsty, and unexplained weight gain or weight loss could also occur. And if they have a wound which is not healing, it is better to have a check on their blood sugar. Some of the type 2 diabetes, I always tell my patients, type 2 diabetes patients, it's slow in onset. So first and foremost symptom is no symptoms with type 2 diabetes. They have to have their health checkup or check their diabetes status, or they have diabetes. Or even if they don't have diabetes, they have to screen for diabetes after the age of 30, at least once a year. And that is not enough. You have to do something to prevent type 2 diabetes as well. So for type 2 diabetes, many of them don't have any symptoms. They go for routine test and find that they have a high blood sugar. So increased thirst, increased urination, increased appetite, fatigue, blurred vision. This can occur in type 1 diabetes as well. But type 1 diabetes is dramatic. Many patients lose a lot of weight, pass a lot of urine, and they have weight loss, dramatic weight loss, fatigue, nausea, vomiting. Many of the patients have come to a hospital in a comatose stage, and only after checking the blood sugar, they know that their patient has type 1 diabetes. We last month we had a 19-year-old girl who came gasping to a casualty, and she survived. She was found to have a high blood sugar with ketones of 6 or 7. Her pH was very low and was found to have type 1 diabetes, was treated appropriately, and she survived and doing well now. So they can come in a comatose state as well to the hospital. So patients with type 1 diabetes usually develop symptoms over a short period of time, and the condition often diagnosed in an emergency setting. For type 2 diabetes, this is the first reason why people develop type 2 diabetes, insulin resistance. So diminish sensitivity of target tissues to the metabolic effects of insulin is one of the important things, first thing to occur in a type 2 diabetes patient. Why does it occur? As I've said previously, if they are sedentary, they are taking more carbohydrate, large carbohydrate meal with a high glycemic index, and they are having obesity, there is a very high chance that they can have insulin resistance. So what happens when the cells becomes resistant, they have less glucose uptake by the cells because the insulin is not acting on the cells, target cells. Plasma glucose goes up, and type 2 diabetes develops. So hypoglycemia, why do we need to treat it? We can just leave. If you ask a patient, why do we need to treat? They just don't know what happens when they have a high blood sugar. You are doing a preventive job, not, in type 2 diabetes, you are not treating anyone. You are doing a preventive job for complications, preventing complications for a patient with diabetes. What can happen? So you can have retinopathy, you can have nephropathy, you can have peripheral vascular disease, you can have neuropathy. This neuropathy and a peripheral vascular disease also can lead to amputation. So the macrovascular disease, you can have, acute stroke or acute coronary artery disease, and, peripheral arterial disease with macrovascular complications. You can divide the complications into macro and microvascular complications, and this can lead to problem, or you have to spend more for treating the complications when you have diabetes. So diagnosis, how is it made? You check the fasting glucose and HbA1c. You can do a C-peptide level, but you don't need to do a C-peptide level all the time. It is only to differentiate between type 1 diabetes and type 2 diabetes. If you do C-peptide level, you can do a glucose tolerance test and urine glucose, all will give an idea whether you have diabetes or not. So the criteria for diagnosis of diabetes, all patients should have a HbA, the fasting blood sugar of less than 100, or 2-hour post-load blood sugar of less than 140. This is a normal criteria for non-diabetic. So if they have impact their fasting glucose, the fasting glucose should be in between 100 and 125. If it is more than 125, it is diabetes. And the postprandial impact glucose tolerance is when the postprandial blood sugar is between 140 and 199. These two are branded as pre-diabetes. This, when they have a blood sugar of between these levels, then it is meant that the patient is having pre-diabetes. So diabetes, if the patient has a high blood sugar of more than fasting blood sugar of more than 126, then it is diabetes. And if the postprandial is more than 200, it also means that the patient has diabetes. Another blood test is blood test with the memory. It's called HbA1c. Nowadays, previously, they were used to treat patients with the one value alone, that is fasting or postprandial. But the HbA1c, which is a glycated hemoglobin in the blood, picks up the glucose in the bloodstream constantly, and it becomes, a part of hemoglobin. So these are called as glycated hemoglobin. The level of glycated hemoglobin depends on the level of blood sugar in your body over a previous 6 months, 3 months. So if you check HbA1c and if it is high, then it means that at least for the last 3 months, the patient has been having a poor glycemic control. So coming to the management of diabetes, the major components of treatment of diabetes is diet and exercise, oral hypoglycemic therapy, and insulin therapy. So if a patient is being given medicine or given insulin, if they don't change their lifestyle, they don't change their diet or exercise, which is the main cause of their diabetes, nothing is going to change. So you have to stress that they have to change their diet and exercise and do regular exercise to treat diabetes or prevent diabetes. So diet is a basic part of management in every case. Treatment cannot be effective unless adequate attention is given to ensuring appropriate nutrition. Aim is to control the weight, adequate nutrition requirements, good glycemic control, and correcting associated blood cholesterol level as well. So what in India at present, now the problem is excess intake. What they say is you have to reduce the portion size. There is no point in asking them to cut short all the rice or rice related products, or ask them to cut wheat or wheat related product, or go to millets. No need to drastically change your diet, but what is important is to take lesser amount of food and prevent, avoid taking certain amount of food, which are, fried items, sweets, and also juices. So what I tell my patients is to avoid these three things alone. That is, fried item, whatever is put in oil, it is better to avoid, not to take much of those. Any item which has been made sugar, fruits are okay. Fruits are actually good, but you should not make it as a juice. Juice will increase the glycemic index and can cause an increase in blood sugar. And also sweets. Sweets are taken in a large amount of quantity, it can lead to problem. Preventing cigarettes and limiting alcohol also are important in the management of type 2 diabetes or type 1 diabetes. So the pyramid one is to guide the patient how much they can eat. So these are the cereals, whole nuts. There are cereals, grains which can be good, but it has to be taken in a limited quantity. The portion size should be less. You can almost have everything, but you have to reduce the quantity of food you take. Eat more veggies and get daily physical activity as well. So good news about physical activity is regular physical activity can able to manage your weight, manage your heart disease, need medications possibility would be less, and they will gain the energy. If you don't do it, they will gain energy. um, they will lose their well-being and improvement in their health. Overall health will be down. So if you do regular exercise, apart from this, there are many other things as well. It secretes when you do physical activity. You release endorphins from brain, which gives happiness to you. So this happiness will give you a state of well-being as well. There are other things as well. You can have reduction in cancer incidences. You can have reduction in improvement in immunity as well for a patient when they do regular physical activity. I always do, brisk walking and things, but you can do a physical activity which will be also interesting for you. For example, you can join a gym, you can join a gym, but gym and other things you have to go. Whatever you do, you have to do it regularly. If you don't go for a walk, you have to go for a gym. Don't go for a walk, you go for the swimming, dancing, doing regular playful things as well are very important. The children now are kept at home and given gadgets to work with at home. They don't have physical activity. I remember my childhood days where I don't stay at home at all when it is a holiday. So we go take a cycle, roam around, and nowadays nobody is going out at all, especially children, and they learn that in when they grow up as well, and they don't want to do any physical activity even when they grow up. That is the main cause of problem. So apart from that, medicine also makes an important part of diabetes management. There are previously about 30 years back, 20 to 30 years back, there were only 2 or 3 agents available to treat diabetes, and only one insulin. But now we have so many medications, metformin, sulfonylurea, DPP-4 inhibitors, thiazolidinediones, SGLT2 inhibitors, alpha glucosidase inhibitors, bromocriptine, colcivalum, and also you have oral GLP-1 analog as well. Now, and injectable, you have GLP-1 analog and insulin. Previously, we were all compelled to believe that reducing the blood sugar also will alone bring down the rate of complications development in the patients. But it is not the game. It is not the game. Now, what the guidelines, the American Diabetes Association or the European guidelines all say that you have to individualize the patient. You cannot give the same treatment for a 30-year-old and an 80-year-old. You can't have the same blood sugar level for a 30-year-old and a 80-year-old. So you have to be more flexible, because insulin and or other medication can cause side effects for the patient. The complications for the patients can be aggravated, and if they have a complication, you should not give certain amount of certain medications. What about insulin? See, whatever medication we give always revolve around the normal physiological profile of serum insulin concentration. You have a basal insulin, which maintains our blood sugar during the fasting state. And when you take a meal, each time the blood glucose The insulin level goes up as the blood glucose goes up and controls the blood sugar. So this is a breakfast, lunch, and dinner. The blood sugar goes up. And the insulin should be given in such a way that it mimics the basal and insulin and bolus insulin when you take a meal. There are different types of insulin delivery. You have pen, you have syringe. You have to be very careful when choosing what type of insulin you are choosing and what is the unit of insulin you are giving. We have many problems in the wards and hospital where there is interchange. 40 unit insulin should be given in a 40 unit syringe, and 100 unit syringe should be 100 unit insulin should be given in a 100 unit syringe. If you say if a patient is having a 100 unit vial of insulin and you are giving it in a 40 unit syringe, then the patient would be getting 2.5 times more than what you expect to give, and that can cause severe hypoglycemia. Or if you're giving a 40 unit insulin in a 100 unit thing, you would be giving 2.5 times lesser insulin, which can cause hypoglycemia. There are now other insulin delivery systems. You will all be familiar with pen insulin. You have different pens and analogs. Analogs are shorter acting insulin, which would mimic the normal insulin secretions in the body. And inhaled insulin is also available, but there are a lot of problems with it. Many of my patients are on insulin pump. This is a constant delivery of insulin to catheter, and which is embedded in the subcutaneous tissue. This is a pump which delivers insulin constantly. It can be changed. The doses can be changed to different times, different delivery levels. And there is closed loop as well. I always tell my patient, you have to monitor your blood sugar. Monitoring blood sugar is very important. You have CGMS, where you continuously check the blood sugar over 14 days, and you can adjust the dose of insulin. So these are some of the delivery devices and things which are modern, which are from it has evolved over a period of 100 years from what Banting and Best discovered to this time to mimic the normal insulin secretion in our body. So other things are coming to oral antidiabetic agents. Metformin, as you know, this is one of the standard drugs. According to me, most of the patients should be on it unless they are intolerant to metformin or if they have renal failure. Otherwise, it prevents the insulin breakdown from liver, and also it decreases the insulin resistance in the peripheral cells and the lipid, the fat cells, where it can make the blood sugar go down by making them work properly. Sulfonylureas are other older medications which are widely used in India. Sulfonylureas, the only problem with sulfonylurea is they can cause hypoglycemia because it acts directly on the pancreas, increasing the insulin secretion and by the beta cells of pancreas. Sulfonylurea main side effect is this hypoglycemia. Hypoglycemia symptoms, the patient can feel weak, shaky, sweaty, and they can have palpitation, confusion, fainting, and loss of consciousness. Any medication you give should not cause hypoglycemia to the patient, which the hypoglycemia can also prevent them changing their lifestyle. They won't change their lifestyle if they are having low blood sugars. Incretin hormone is one of the modern thing, even though this has been reported in 1900 itself. The importance of incretin hormones have been widely accepted recently, because what it does is it acts on the pancreas to increase the insulin secretion, decrease the glucagon secretion, whereby in a insulin dependent, in the glucose dependent manner, if the blood sugar is high, it will stimulate. If the blood sugar is low, it won't stimulate. So this is present normally in the body. But what happens is the DPP4 enzyme degrades it very quickly. So we have medications, linagliptin, sitagliptin, and saxagliptin, which increases the GLP-1 level in the body. And they also have a injectable GLP-1 itself given to a patient, which can increase the insulin secretion and decrease the glucagon secretion according to the blood sugar. There are other oral hypoglycemic agents, all the people who are familiar in cardiology would be knowing about SGLT2 inhibitors, that is canagliflozin, dapagliflozin, and empagliflozin, which are found to be more beneficial for the heart as well. So this happens when you use SGLT2 inhibitor is blocks the glucose reabsorption from the kidney. So the kidneys, excrete more glucose in the urine, and that will decrease the blood sugar. The alpha glucosidase inhibitors, acarbose or voglibose, bromocriptin, which has not been widely used, or colbislam, swellum, can also cause decrease in blood sugar, due to unknown mechanism. So the targets for a healthy life is the ABCD mantra, where A for A1C, which should be less than 7. Blood pressure should be less than 140/90. BMI should be less than 23. And cholesterol should be less than 100 with drugs and discipline that you have to maintain to reduce these important risk factors for diabetes. So summary treatment of diabetes is you have to improve the diet, change the diet, reduce the portion size, include more vegetables, fruits rather than processed food. Regular physical activity is a must, and medication to control the blood sugar should be taken regularly, and self-management of lifestyle is also important. So saying no to certain things like a processed food or juice or sweets are very important, and accepting and sticking to main things like fruits, vegetables, and a healthy lifestyle is very important to maintain very good health. So health is wealth. Nowadays, the medication cost is very high. The hospital cost is very high. Anybody can have ill health, but people who have poor health will also have all these problems and can affect their wealth as well. They can't spend more time to be wealthy as well. So prevention is better than cure. Doing some physical activity and saying no to certain things would prevent diabetes, and this is better than trying to get a cure for that. I did like 5 kilometers of running today, and this is what I do every day, do regular walking or some sort of physical activity even at home. Thank you for patient listening. I hope this would be helpful for changing your lifestyle or preventing diabetes in you and treating your patients as well. Thank you.
Thank you, sir. Thank you for the enlightening session on diabetes. It deepened our understanding, and a very interesting history on diabetes mellitus. Reminded us the importance of our healthcare, healthier lifestyle as well. I request Ms. Hira Krishnan, who is working with Srinivasan sir.
There are few questions which I will go through
Yes.
quickly.
Yeah, I request Hira to say some few words, sir, and then we'll take upon the questions. Hira, you should unmute yourself.
Good evening, everyone. I'm Hira, physician assistant, works in GKNM Hospital as a physician assistant. I'm a joint secretary of Tamil Nadu IAPA. Thank you, sir, joining us for understanding DIM in essential. We truly appreciate your time and participation. We hope we found the session informative and valuable. It was a pleasure sharing insights on topic understanding diabetes is essential. Stay informed. On behalf of our team, I want to extend our sincere thanks to Dr. Srinivasan, diabetologist and endocrinologist, GKNM Hospital. Your insights on the topic were both enlightening and engaging. We truly appreciate that the time and effort took to share expertise. Thank you, sir. Thank you all once again.
Yes, we can take the questions, sir.
Right. For the lack of time. The first question is about GTT. GTT nowadays, it is time consuming asking the patient to wait, drink a large amount of glucose and ask them to wait for 2 hours. It's a cumbersome process, so it has lost its significance not in a normal person, but it's still being used in gestational diabetes to diagnose gestational diabetes. So gestational diabetes also, they are moving to GCTs where you do one blood sugar alone and find out whether you ask them to drink and then do a blood test after 2 hours. GCT. So GTT is done only in certain things where you want to find out whether the patient has reactive hypoglycemia. So you can very well do fasting postprandial and HbA1c, which will give the diagnosis, clinch the diagnosis. You don't need to do a GTT for them. How do you titrate the hypoglycemics with the help of 3 values, fasting, postprandial, and HbA1c? You have to be aware that you have to be knowing about the patient's habit as well. If the patient is having normal hemoglobin and the hemoglobin is low with the fasting and postprandial high, the patient is having a good control all the time. So you don't need to escalate the medication. But if they are having all those things high and the patient is not see, there are many things, whether the patient taking medication, whether they have left the medication while coming to the hospital, those things will affect the fasting and postprandial blood. HbA1c means that the patient is taking the medication and still not enough, whether it could be diet or exercise or the medication. So, 3 values may not be enough most of the time. Sometimes enough. You have to do a CGMS or ask them to monitor the blood sugar at home, which will give us an idea about what their control was previously. So what does it mean to have a normal fasting and a low postprandial, much lower than the non-diabetic range in diabetics, which means that a sulfonylurea or an insulin you're giving would be at a higher dose. You need to reduce those doses, or their insulin secretion after a meal is very high, or if the patient is having a nocturnal hypoglycemia, the fasting blood sugar would be high. There are many other things you have to think about when they have a low postprandial blood sugar and a very high fasting blood sugar. You have to go deeper into their history if they have this type of things. How often should a diabetic test their blood glucose levels? Frequently, at least once or twice a week, so that they know what their changes are. But once in 3 months, HbA1c is a must. They have found that if you are having a regular follow-up with HbA1c test and thing every 3 months, they have a quite good glycemic control rather than person who is coming every year or every 2 years. So every 3 months or 4 months should be okay for doing a HbA1c. So the other question is, can you explain when metformin should be avoided despite being first line? So that is, I've mentioned that in my talk, you have to avoid metformin really if the patient is having intolerance to metformin. Main intolerance is GI intolerance. If they have diarrhea, if they have abdominal pain, or if you have severe renal impairment, they now say even if the GFR is like 30, you can give metformin. But if the patient is having stage 4 or 5 renal failure, then it is better to avoid. In liver failure or in severe cardiac failure, it is better to reduce the dose of metformin. Cardiac failure alone is not a contraindication for metformin. How frequently should non-diabetic adults test for the blood glucose? Every 6 months, they have a proper lifestyle. Then every 3 months, every 1 year, they have to check if they have diabetes after the age of 30 or 35. Dietary advice is most practical to give rural places with low health literacy. Take less, half of what they eat should be enough. Most of the patients in the rural areas take a large amount of rice, and many patients from rural areas say they take 8 idlis, but the farm work now has gone down with the modern equipments for farming. So they have less work, but they eat a large amount of carbohydrates, which can be prevented by asking them simply to reduce their dietary intake of carbohydrates. Reversal of diabetes, if you follow a healthy lifestyle, it is reversal. It is possible. You have to stick to whatever you are doing for lifelong. The cost of insulin pump is about from now it is from 3.25 lakhs to 7 lakhs. Closed loop insulin pump is about 7 lakhs. They are quitting. And inhaled insulin, I have not used. We don't know what is the long-term effect of going to be of inhaled insulin. And in that too, it is not a long-acting insulin, it's short-acting insulin. For a long-acting insulin, you still have to give a shot. Metformin indicated for obesity? Yes, it is indicated, but it doesn't reduce the weight dramatically. There are weight loss medications now available. That is GLP-1 analogs. Wegovy is a recent launch which was launched about 2 days ago, which is a injectable semaglutide, which is very effective in patient. And there is tirzepatide, which is called as Mounjaro, which is also available, which is an injectable agent which makes people lose weight. Even Ajit Kumar is supposed to be having that Mounjaro injections to lose weight. How many units of insulin will be given to hypoglycemia patient? Hypoglycemia patients, it's better not to give any insulin. And if they have type 1 diabetes, ask them to reduce their dose of insulin. What indicates if fasting blood sugar is within normal limit and postprandial is more than the normal. If they are eating well, a lot of sugar, that is what it means. Should the anti-diabetic therapy be adjusted in patients with renal impairment? Renal impairment, linagliptin can be given. Other gliptins have to be more carefully given. Sulfonylurea given cautiously. Glycoside is one of the important things. When they have severe renal impairment, metformin should be. Insulin is the best option when they have severe renal impairment. I have answered almost all the questions. I think for the lack of time, I think we can close the session.
Thank you, sir. Thank you so much for giving us this enlightening session and spending us with us. Your time is precious for it. In spite of your clinic time, you have given this session for us. Thank you so much. We'll be disturbing you in future also. So thank you, sir. Thank you so much. Thanks a lot.
Thank you.